All right, I have the privilege of introducing our next session. And I just want to take a moment and say, as someone who's started to take a little bit more of a backseat within eSAS stuff, how amazed I am by the quality of the presentation, and thankful to Kristen, Loren, and everybody who worked to organize today, and everyone that came as speakers. Thank you again for the time and commitment to this community. It's really just an amazing community to see grow and support each other. And this next session really is in that vein. So I'm going to be very brief in my introduction and not introduce each of the speakers, but really one of the things that I think we heard highlighted earlier on was the importance of peer-to-peer and near-peer mentoring and connections. And one thing that the community sort of felt was needed was a chance to understand what are your peers working on, and who they are and where they're at, so that if you're working on something similar or adjacent, or just looking for a collaborator or somebody who's a step ahead of you, you can know who those people are. So with that, I will go ahead and get out of the way for our first speaker, who I believe is Broc Burke from Washington University.
Good afternoon, and thank you for joining us for this rapid fire showcase. My name is Broc Burke, and I'm with Washington University in St. Louis, and today I'll be discussing how we've been working to illuminate ischemic stroke using near-infrared spectroscopy. I have no disclosures, and I would like to start by giving you some background on why we decided to perform this study. As many of you are aware, stroke is a major health issue both in the United States and internationally. What you may be less aware of is, as early as 2010, correlations between the functional connectivity in the brain using an MRI were being shown by Carter et al., while nearly at the same time in 2009, White et al. Were showing similarities between the results of functional connectivity MRI and functional connectivity diffuse optical tomography, which uses that near-infrared spectroscopy that I was mentioning. Now, why would we try to look at results using FCDOT? Well, it's significantly less expensive, $100,000 versus $3 million, and it's portable enough to make it bedside, which becomes really interesting when you realize you could have the potential of using it as a monitor as opposed to the current Q1 or Q2 hour neuro checks. Now, what you'll see here is the wavelengths that our system is using. We're using 750 nanometers shown here, and 850 nanometers shown here, basically giving us sensitivity to both the oxyhemoglobin shown in red and deoxyhemoglobin shown in blue, while being outside of the absorption spectra for lipids or water. Furthermore, we're using the same physiology that is exploited for fMRI, where we know that given a stimulation, whether that's finger tapping, some noise, speaking, that you then have an inrush of oxyhemoglobin in a given region and a corresponding decrease in deoxyhemoglobin. With that information, if you put together a system similar to that shown on the left, which is what we were using for this study, then you can get an image that you see on the right, which is the time course of that activity over time. Now, I've been talking about functional connectivity, and what that is the temporal correlation from one area of the brain to another. So, looking at that red circle, you see the time trace of the activity for that red circle. And then on the contralateral side for the orange circle, as you would guess, given bilateral connectivity, they're going to have similar time courses as shown by that correlation coefficient of 0.52. Now, if instead I looked at the correlation between that red circle and the blue one, then I have less functional connectivity, or in other words, less temporal correlation over time. The next step that we did is we looked at what the functional connectivity looked like in stroke as compared to normal subjects. So in that top column, what you're looking at is first the field of view for our system, and then in each one of these, you're going to notice a black dot, which is what we're using for the time course to compare for the rest of that image. And in this case, in that top row, you'll notice that you have that bilateral connectivity, and no surprise that within the areas directly adjacent to the seed, you also have functional connectivity. So that middle column is the right motor seed column, and then the far right one is the visual seed column. Now, the next thing that we did is I've given you 3 example stroke subjects with NIH stroke scales of 2, 17, or 27. So getting worse as we go down the screen. And as you would likely guess, the size of the infarct shown in red for these CT scans is larger for each one, And a different way of looking at it is just projecting that out to the gray and white matter interfaces. Now, what you'll additionally see is with a relatively small stroke, the bilateral connectivity is relatively well intact for both the motor and the visual seeds that we're showing you here. For the mild stroke, then when you go up to the United Stroke Scale of 17, that motor bilateral connectivity fell apart. However, the visual was still intact, and then it goes away completely when we're looking at the severe stroke. The next step, given that I was just showing you example functional connectivity maps there, is to do a spatial correlation of those against young healthies, and then also doing that for age matched. When you do that, you end up with a similarity measure. Now, if you look at the similarities for our age matched versus our stroke, you have a nice separation as shown both by the p-value and the strength and just visual inspection. Similarly, if you looked at the similarity versus the NIH stroke scale shown at the bottom there, we also end up with a nice correlation, again shown with that p-value and the r-squared value there. So in the end, I've shown you that we have that correlation of the similarity and the NIH stroke scale, and I'd like to thank the NIH, IARS, and everybody in the lab. Thank you for your time.
Today, I'll be talking about opioid prescribing patterns for surgical patients. I have nothing to disclose. As we all know, we are in the middle of an opioid epidemic. And in 2018, 15% of the US population filled an opioid prescription, and about 30% of those were prescribed by a surgeon, making the perioperative period a critical component of the epidemic. Specialty guidelines have recommended multimodal analgesia to improve pain control and reduce opioid consumption, specifically with the addition of acetaminophen, NSAIDs, and gabapentinoids. And this is exactly what I noticed on my clinical rotations during residency. Of course, this is not new information. We have seen decades worth of studies that have proven that when you add multimodal to post-op pain regimen, that you reduce overall opioid consumption. And that is precisely what we're doing in my institution for our surgical patients. However, despite reductions of opioid use in the inpatient setting, I was curious what is happening at discharge for these patients. And what I found is that there is significant variation in discharge prescribing patterns for surgical patients. Studies show that only 10 to 60% of opioids filled are taken, and a large number of patients report keeping their extra opioids, not returning or disposing of them. And why do we care about excess opioids? Well, they result in chronic use, overdose, and diversion into the community. Which brought me to my research question. How does pre-discharge pain regimen, which includes opioids and non-opioids, correlate to our discharge pain medication prescriptions? So using electronic medical record data, we have over 32,000 patient encounters, and these encounters include opioid-naive patients undergoing surgery requiring an inpatient stay. We see that the average age is 55, 52% were female, the average length of stay was 3.4 days, and 83% of our patients were discharged with an opioid prescription. This graph shows the percent of surgical patients that consume multimodal analgesia in the day leading up to their discharge from hospital. So again, this is inpatient consumption of multimodal prior to discharge. And we see a steady increase in all three medications, Tylenol, NSAIDs, and gabapentins. And this is the trend that we would expect to see with increased promotion and adoption of multimodal, accompanied by institutional protocols such as ERAS. In the day prior to discharge from the hospital, our patients have had decreasing opioid requirements over the past 6 years, from a median of 30 OMEs being consumed in 2012 down to only 18 OMEs in 2018. Again, this shows the opioid consumption in the last day of hospitalization has been decreasing. In the gray, we have the daily oral morphine equivalents on the discharge prescription. This is the daily dose our patients are being sent home with. And we can see our surgical patients are being sent home with a much higher daily dose compared to their daily dose in their hospitalization. The discharge daily OME peaked at 90 OMEs in 2014 and then decreased to 60 OMEs by 2018. So to summarize, we saw that multimodal was increasing in our hospitalized surgical patients. Their opioid requirements were decreasing while they were in the hospital. However, our discharge prescriptions are much higher daily doses than the daily doses they required on their last day before discharge. When we looked at a subset of patients, those who did not take any opioids in the hospital and they did not have a nerve block potentially covering up pain, we found that 25% were still discharged with an opioid, and 10% of those prescriptions had a daily oral morphine equivalent dose of greater than 90, which I'm highlighting as this dose has been cited as high risk for its increased likelihood of an overdose event or a misuse event. So in summary, we have an increased administration of multimodal and reduced opioid consumption while the patients are in the hospital. However, there still remains large discrepancies in inpatient opioid consumption compared to the discharge prescriptions. Thank you so much, and I'll leave time for questions and comments.
Hello, my name is Loren Smith, and I'm an assistant professor of anesthesiology at Vanderbilt University Medical Center. Today, I'm excited to tell you about my research examining high-density lipoproteins as a potential novel therapeutic for postoperative acute kidney injury. I have nothing to disclose. Postoperative acute kidney injury, or AKI, is the second most common form of AKI in hospitalized patients. It's associated with an increased risk of the rapid development or progression of chronic kidney disease as well as death. Mechanisms of AKI include inflammation, oxidative stress, endothelial dysfunction, ischemia, and nephrotoxins. Now, there are particles in the human body known as high-density lipoproteins, or HDL. Many HDL functions may counter known mechanisms of AKI. For example, HDL has anti-inflammatory and antioxidant properties and promotes endothelial function and health. For this reason, we wondered if HDL might play a role in the prevention of AKI. We began to examine this question by looking for an association between HDL concentration and postoperative AKI. Using a latent variable mixture modeling technique we developed to account for unmeasured confounders, and after adjustment for known AKI risk factors, we found that a higher preoperative HDL cholesterol concentration was associated with a lower maximum 48-hour postoperative serum creatinine change from baseline. Importantly, we also found that the association between higher preoperative HDL and less postoperative AKI could be pharmacologically potentiated during the perioperative period with high doses of atorvastatin, suggesting that therapeutics might be developed which could increase HDL concentration or function and reduce AKI. Unfortunately, although statins potentiate the relationship between higher HDL and less AKI, perioperative statin treatment does not decrease AKI, likely due to non-HDL-mediated harmful renal effects. Therefore, to begin to rationally develop HDL-based therapeutics for AKI prevention, we needed to examine the roles of different HDL functions in acute renal injury. It has previously been demonstrated in rats that the administration of exogenous small HDL particles before renal ischemia reduced AKI and renal oxidative stress, which was measured as MPO activity in the renal parenchyma. Interestingly, HDL's primary antioxidant enzyme, PON1, is known to directly inhibit MPO activity. We decided to see if higher HDL concentrations were associated with higher PON1 antioxidant activity and less oxidative stress in surgical patients. To do this, we examined the relationship between HDL concentration, PON1 activity, and isofuran concentration in 75 cardiac surgery patients who developed AKI and 75 matched control patients. Isofurans are an in vivo marker of oxidative stress. We found that higher preoperative concentrations of HDL particles were associated with higher plasma PON1 activity and lower plasma concentrations of isofurans immediately after surgery. Now, in other patient populations, it's been observed that the majority of PON1 associated with HDL resides on small HDL particles. When we examined the relationship between HDL particle size and systemic oxidative stress during surgery, we found that only higher concentrations of small HDL particles were associated with lower isofuran concentrations. There was no association between medium and large HDL particle concentrations and systemic oxidative stress. Therefore, our data suggests that PON1 on small HDL particles may underlie the relationship between higher HDL and less postoperative AKI. HDL also has known anti-inflammatory effects that might influence the development of postoperative AKI. In macrophages, HDL induces the expression of activating transcription factor 3, which reduces intracellular production of TNF-alpha and IL-6, cytokines associated with AKI. Additionally, the interaction of apolipoproteins such as ApoA1 with a cell surface receptor known as ABCA1 can inhibit the transport of toll-like receptor TLR2 and TLR4 to the cell surface. TLR2 and TLR4 mediated inflammation is known to contribute to AKI. Therefore, peptides that can interact with ABCA1 on macrophages might reduce systemic inflammation and AKI development. During my graduate studies, we identified the minimum necessary structural motif of apolipoproteins necessary for interaction with ABCA1, and it's shown here on the right. In these helical wheel diagrams, hydrophobic amino acids are denoted in blue. We found that the combination of a poor lipid solubilizing helix, shown on the left, and a good lipid solubilizing helix, shown on the right, allowed an apolipoprotein to interact with ABCA1. Peptides with this motif might be able to mimic HDL's inhibition of TLR2 and TLR4 mediated inflammation. This peptide motif has been further developed by my collaborator, Dr. Alan Romali, and his colleagues at the NIH, and they are just about to begin a phase 1 human trial of this therapeutic. Our future directions involve delineating the mechanism of HDL protection from AKI, identifying HDL protein and RNA cargo associated with renal protection, and rationally designing clinical trials of HDL-based therapeutics for the prevention of postoperative AKI. I would like to thank all of my colleagues, mentors, and collaborators.
Thank you very much
for your attention.
Hi everyone, my name is Mike Devinney, and I'm an assistant professor at Duke University. Today I'm going to talk to you about our Sandman study, which investigates the role of sleep apnea in neuroinflammation and cognitive dysfunction after non-cardiac surgery. I have no financial relationships or commercial interests to disclose. So what is postoperative cognitive dysfunction in delirium? Well, delirium is an acute confusional state characterized by inattention, disorganized thinking, and disrupted awareness that occurs typically 1 to 3 days after surgery. Cognitive dysfunction, on the other hand, is characterized by cognitive deficits, or thinking and memory deficits, found on neurocognitive testing weeks to months after surgery. Both of these neurocognitive complications are associated with increased mortality, more frequent complications, and decreased quality of life. Despite these problems and how common delirium and cognitive dysfunction is in older adults, we have no good treatments to prevent these conditions, and we don't really have a good understanding of their mechanisms or risk factors. One possible risk factor for delirium and cognitive dysfunction after surgery is sleep apnea. Sleep apnea is a disorder characterized by upper airway obstruction during sleep, which results in apneas and hypopneas. These apneas and hypopneas can cause decreased oxygen levels intermittently throughout the night that also disrupt sleep, as you can see here. These alone could actually cause cognitive problems in patients, and sleep apnea has been associated with mild cognitive impairment and a higher likelihood of developing Alzheimer's disease. In addition, has been also associated with findings of increased Alzheimer's disease neuropathology and faster cognitive decline in patients who have dementia or Alzheimer's. So Alzheimer's disease could be one mechanism through which sleep apnea causes cognitive dysfunction. Another potential mechanism is neuroinflammation. Patients with sleep apnea have increased peripheral inflammation as measured by serum markers. These inflammatory mediators could cross the blood-brain barrier and evoke neuroinflammation. This is the focus of the Sandman study. There are alternative hypotheses or mechanisms through which sleep apnea could cause cognitive dysfunction, including impaired synaptic plasticity, altered cerebral blood flow through altered cerebral autoregulation, sympathovagal imbalance, and reduced brain oxidative metabolism, just to name a few. But our focus is on neuroinflammation. So the first aim of the Sandman study is really to determine the extent to which sleep apnea and its severity is associated with postoperative cognitive dysfunction, as measured with a neurocognitive testing battery. Second aim is to quantify the extent to which sleep apnea and its severity is associated with neuroinflammation, as measured by cerebrospinal fluid cytokines. So what is our study design? Well, Sandman is a sub-study of Intuit, which is my mentor study that investigates the role of neuroinflammation in postoperative cognitive dysfunction. Older patients that are scheduled for non-cardiac, non-neurologic surgery are enrolled in the study and undergo baseline cognitive testing. Then we perform a lumbar puncture to obtain cerebrospinal fluid, and we also obtain blood samples. After surgery, 24 hours, we perform lumbar puncture again to collect cerebrospinal fluid and also collect blood. And delirium screening is performed every 12 hours until hospital discharge or post-op day 5. 6 weeks after surgery, postoperative cognitive testing is performed and compared to baseline cognitive testing. We also collect CSF and blood at that time. The goal of the Intuit study is to determine the relationship between neuroinflammation as measured with CSF cytokines and cognition. So what does the Sandman study add? Well, Sandman adds home sleep apnea testing. Patients that are on sleep apnea treatment are excluded, but many of the patients we enroll are not. And with home sleep apnea testing, which measures oxygenation and breathing, we can determine the apnea-hypopnea index for sleep apnea severity in the patients in our study. We also measure sleepiness with the Epworth scale, as well as perform sleep apnea treatment questionnaires, which assess whether patients initiated treatment for sleep apnea and the degree of adherence to that treatment. Finally, the end goal of the Sandman study is to determine the relationship between sleep apnea and CSF cytokines and sleep apnea and cognition. So where are we in Sandman? We're not finished yet, but we're nearing the finish line. We aim to enroll to perform sleep apnea testing in 80 to 100 patients. And right now we're at 79. So far, we've screened a number of Intuit patients, and many of them of which are already on OSA treatment. And as you can see, a number of patients are unable to go from dropping out or other attrition in Intuit. But most patients that have undergone sleep apnea testing have successfully completed it. And of the 79 patients that successfully completed sleep apnea testing, 62% have some form of sleep apnea, which about half of those having sleep apnea having mild, another half having moderate to severe. So there's a significant burden of undiagnosed, untreated sleep apnea in our older adults coming in for non-cardiac surgery and enrolling in our study. So we are excited to share the results of this study with everyone. We hope to be done this summer or fall. And I'd like to thank my funding source, the Foundation of Anesthesia and Education Research RFG grant, which funds Sandman, and then my mentors NIH K76, which funds Intuit. I'd like to thank all my mentors who have supported me in this work in this early stage of my career, and thank the whole team. It really takes a big team to complete these studies. And I'd like to direct you to my email for any
Questions, michael.devinney@duke.edu, and I look forward to chatting with you in Q&A.
Good afternoon. My name is Mitra Heshmati, and I'm a Bonincke Scholar at the University of Washington. Today, I will tell you about my research studying neural circuits and emergence from anesthesia. And I have no financial relationships to disclose. The overarching question guiding my research is, what is the emotional experience of emergence? James Eckenhoff and colleagues described this phenomenon of post-anesthetic excitement in 1961. Since then, over 50 years later, we still can't reliably predict or modify these behaviors. So when our patients are waking up from anesthesia, we don't know, will they manifest confusion, hyperarousal, agitation, or delirium? And part of why it's been so difficult to study this question is we can't ask our preclinical subjects, they feel happy, sad, excited, or anxious, at least not directly. In order to use preclinical models to study these complex emotional state transitions, we need to design good models and then translate our neural circuit investigations to a clinical application. By using a preclinical model, we can take advantage of technological advances such as optogenetics to causally manipulate neurons at the speed of neural activity. And conversely, using fiber photometry to record neural activity with calcium release as a proxy for activity. So in my studies, I'm using the model of the writing reflex, which has been commonly used as a correlate for return of consciousness in rodents. Here I'm recording neural activity using a genetically encoded calcium sensor and fiber photometry, while a mouse is emerging from isoflurane anesthesia. Specifically, I'm using machine learning approaches to record the location of the mouse in space, and importantly, to create models that classify this emotional and behavioral state transition. My circuit of interest is the mesolimbic dopamine circuit, classically called the brain's reward circuit. However, we know it's important for more than just simple reward, and it's critically important for arousal. The brain regions I'm interested in are the ventral tegmental area, shown in purple, and the nucleus accumbens, shown in the bright blue. The ventral tegmental area sends a predominant dopaminergic projection to the nucleus accumbens, which then acts as an integral hub, taking in inputs from different brain regions in the reward circuit and integrating them to change behavior. The ventral tegmental area, also called the VTA, has been shown to be important for emergence. Direct electrical stimulation of the VTA promotes emergence, as well as optogenetic stimulation of just the dopamine neurons in the VTA, indicated by increase in restoration of writing. In addition, optogenetic stimulation of the VTA promotes arousal from sleep. However, the VTA is not just a collection of dopamine neurons. There are many neuronal and non-neuronal cell types in the area. In my studies, I'm taking advantage of transgenic mice to isolate the contribution of dopaminergic, glutamatergic, and GABAergic neuronal cell types in the VTA to emergence from isoflurane anesthesia. So here's an example recording from GABAergic neurons in the ventral tegmental area as a mouse is emerging from isoflurane. Here you can see there's a gradual increase in GABAergic neuronal activity, time locked to restoration of the writing reflex. In parallel studies, I'm looking at dopamine release from the VTA to its projection regions, like the nucleus accumbens, using the dopamine sensor D-Light. So in the top left, you can see D-Light expression within the nucleus accumbens, and below that is a heat map showing multiple emergence trials. To the right, you see that there is an increase in dopamine release immediately preceding restoration of the writing reflex. These are preliminary data, and my hope is that as this project evolves, I can use my preclinical findings to inform translational therapies to change our patients' experience under general anesthesia. With that, I'd like to thank my mentor, Michael Brukas, and the Brukas Laboratory for their support, as well as the faculty at the University of Washington and the Golden Laboratory for their help with this project. If you have questions for me, please feel free to contact me at mhesh@uw.edu or message me on Twitter. Thank you for listening.
Hello, my name is Allison Janda, and I'm very excited to be presenting in the Early Stage Anesthesia Scholars Rapid Fire Showcase. So I am a clinical lecturer and T32 research fellow at the University of Michigan in Ann Arbor, Michigan. And I have funding from an NIH T32 research grant, as well as I've received research support paid to the University of Michigan, unrelated to this present work, from Becton Dickinson. And my presentation doesn't include any off-label or investigational use drug discussions. A little bit more about me. I grew up in Southeastern Michigan and attended undergrad at Bucknell University, and went to medical school at University of Michigan, and went to residency then at Vanderbilt University Medical Center, where I was also chief resident, and then came back to Michigan for a cardiothoracic anesthesia fellowship, and stayed on at the University of Michigan as faculty and T32 research fellow. And so I am primarily a cardiac anesthesiologist and working at the Cardiovascular Center. And so to pair those clinical interests with my research interests, I'm focused on identifying areas of variation in anesthesia care for cardiothoracic and major surgery, and then assessing whether this variation is impactful, relevant at all to patient care. And so that it really is represented in questions such as how does the intraoperative practice variation decision-making impact outcomes, the patient experience, or cost after surgery. And then ultimately, the first two aims are really built to examine the effect of our treatment choices on patients prospectively, or to inform those studies, whether they're my studies or other studies. But the goal is to help inform the design of prospective, pragmatic clinical trials to address areas of practice variation with potential impact on patient care and outcomes to better inform our daily clinical practice and care of patients. And so to accomplish these aims, I primarily am leveraging the University of Michigan robust EHR infrastructure, as well as the infrastructure at the Multi-Center Perioperative Outcomes Group, or MPOG, which is a consortium of over 15 hospitals with granular intraoperative and perioperative data. And also in collaborating with sites within MPOG as the Cardiac Anesthesia QI Subcommittee lead, and am assisting in integration of Society of Thoracic Surgery Registry data with MPOG data, which really takes the best of both databases and resources, where we are employing the really robust, adjudicated 30-day outcomes provided in the Society of Thoracic Surgery Registry, and pairing that information with the minute-to-minute granular data across multiple institutions provided in the MPOG database. And so my goal is to help expand MPOG's network and the collaborations within MPOG for primarily retrospective observational studies to then become a leading prospective trials network to take that information that we're learning throughout our retrospective studies to inform prospective work. And so a great example of a multi-center collaboration study within MPOG that I led was the multi-center review of practice patterns regarding benzodiazepine use and variation in cardiac surgery. And we hypothesized that patient factors are not the primary variation and driver of use. And we used a mixed effects and multi-level model to assess random versus fixed effects of variation in benzodiazepine use. And we assessed variance using variance estimates and median odds ratios. So of the over 65,000 patients across 825 anesthesia attendings at 33 institutions, over 58,000 received benzodiazepines, which was about 88.5% of our population. And notably, the adjusted median odds ratio was 2.7 between providers and 4.2 between institutions. This means that if you selected two random providers within our cohort, the difference in odds, or the odds differed for receiving a benzodiazepine by 2.7-fold. And between two randomly selected institutions, the odds of receiving a benzodiazepine within our cohort differed by 4.2-fold, which is a pretty striking variation. And when we examined the variance estimates, we found that 2/3 of the variation in benzodiazepine administration during cardiac surgery was attributable to the institution and provider, which is also very striking. And these findings really demonstrate clinical practice differences between sites and really stress the importance of multi-center collaborations in assessing the impact of any practice patterns on the post-operative care or post-operative outcomes for our patients. And along that same theme, I'm engaging with researchers at University of Michigan, but in MPOG more broadly, assessing inotrope practice patterns and variation in use across MPOG, as well as practice patterns for LVAD procedures across MPOG as well. And then at the single center level, working with single center outcomes associated with inotrope use, using integrated STS and MPOG data, first at that single center level, and then working to expand the number of sites with STS and MPOG integrated data for robust multi-center retrospective studies assessing post-operative outcomes that are used as the fodder or to inform then future pilot studies and pragmatic trials for others or myself as they continue to evolve and develop. Overall, thank you so much for taking the time to listen to my short talk, and I'm looking forward to the Q&A. Thank you.
Hi there, my name is James Kahn. I'm an anesthesiologist and pain physician at the University of Toronto in the Department of Anesthesia and Pain Medicine. I will be speaking briefly today about my research program that is focused on persistent pain after breast cancer surgery. I have no financial relationships to disclose, and my presentation does include a discussion of off-label use of intravenous lidocaine. Now, persistent pain after surgery is a major complication, and across all surgical groups, it's estimated to be approximately 3 to 10%. However, breast cancer surgery specifically is associated with one of the highest rates of persistent pain. We completed a systematic review a few years ago, and across observational studies, we found that the median prevalence of persistent pain after breast cancer surgery was estimated to be 37.5% at a 2-year follow-up, which is a significant proportion of patients that will have persistent pain. The median intensity of pain is not trivial. It's mild to moderate in nature, and our pooled estimate was 3.9 on a 0 to 10 scale. Now, pain will have a number of consequences, including impacting mood, function, quality of life, and costs and expenses on the healthcare system, and is estimated to be approximately $1 billion on an annual basis. Currently, treatment options to treat this pain disorder are limited, and there are no known preventative interventions. So my research program at Mount Sinai Hospital here in Toronto has been dedicated to identify the risk factors associated with persistent pain after breast cancer surgery, to identify preventative interventions that reduce the development of persistent pain, and to identify novel therapies to treat persistent pain once it develops. There are a number of different projects and areas that we're looking into. I will, for the sake of time, will focus on our largest trial that we currently have underway. This is known as the PLAN trial, and is the prevention of persistent pain with lidocaine infusions in breast cancer surgery. This is a large international multi-center randomized controlled trial that I'm leading. We are hoping to enroll approximately 1,200 patients undergoing breast cancer surgery. This study aims to definitively identify the effects of an intraoperative lidocaine infusion that is delivered during the course of breast cancer resection on reducing development of persistent pain. The primary outcome is at 3 months, with secondary outcome at 12 months after surgery. This large trial is based off a pilot trial we completed a couple of years ago in 100 patients across 2 sites that we identified that lidocaine infusion during breast cancer surgery reduced persistent pain by 32%. And although this was a pilot study that was underpowered, we were able to identify a significant finding on reducing persistent pain. Last year, we were awarded $1.3 million from the Canadian Institutes of Health Research to complete this definitive trial. Currently, we are moving forward with 12 sites across Canada, and we have agreement to also conduct this trial at 3 US sites, 2 sites in India, and 1 site in Germany. We have not yet started recruitment. Recruitment will start in the summer of 2021, and we estimate that it will take approximately 2 to 3 years to recruit our total sample size, followed by 6 months of analysis and manuscript writing. As such, we are looking for further collaborators in this trial. If there is any interest in participating in this trial, please feel free to contact me at my email here, james.con@sinaihealth.ca. Furthermore, if there are other potential collaborative projects in this area of pain medicine that would be of interest discussing with me, please feel free to reach out to me. Thank you for listening, and see you around.